This is the additional treatment option. I think this is the end of the journey because first of all, we need to consider everything that has been said before with the clinical workup, the imaging workup, and then finding the fistula. This is a very small number of patients which this talk actually applies to. For the completeness, there's different treatment options: CT-guided patching, as mentioned in the previous talk, or surgery, as mentioned by Jürgen Beck. The transvenous embolization is a new technique, and I think the interesting thing here for the neuroradiology community is that a lot of people working in the angio suite actually got attracted to the topic of SIH because of the possibility of treating it endovascularly. So that's maybe one of the reasons why neuroradiologists, which are actually not so interested in SIH overall, have become attracted. The reasons why CSF fistulas originate where they do is probably the reason that you know all the spinal arachnoid granulations or the anechoic granulations in the transverse sinus. Similar structures are to be found on the nerve root sleeves. So this is the reason why there is a spinal CSF drainage. And probably what we see, if we consider this being a normal drainage, so the nerve root, and these are the spinal arachnoid granulation, this is the normal setting. In these patients which develop CSF fistulas, those spinal arachnoid granulations rupture or become larger. We don't really understand, but probably this is a dysfunction of the spinal arachnoid granulations. It's a one-way mechanism, because what we never see in patients which do have CSF venous fistula, we don't actually see blood in the CSF. So probably the drainage is only unidirectional to the venous system, but not vice versa. This is also important when considering embolization in the vein. It's important to be sure that we don't embolize the other way around into the intrathecal compartment. To familiarize yourself with venous anatomy, I think it's important to mention that there is the epidural plexus, as all of you are aware of, and the area where the fistulas form is along the nerve root or the nerve root sleeve, and where the spinal arachnoid granulations are sitting. We have a longitudinal system of veins that are running along the entire spine, and those are interconnected on various levels, and there's a great variance. But I think the important thing is here that we have intercostal veins or segmental veins, which are connected through intersegmental anastomoses. And out of these, so out of the intercostal veins, we have veins that then run into the foramen, to the foraminal veins, the area where the fistulas are located, no matter if you're treating them surgically, endovascularly, or by CT. This is the level which you are targeting. The technique of transvenous embolization is very, very recent. It's Walid Brinjiki, who is working in the Mayo Clinic in the US, who has first proposed the treatment and has been the one who has definitely done the most. And he proposed it in 2019-20. And these are one of the first cases he shared with us. There's a great technical importance when we are considering embolizing CSF venous fistula. If we consider arteriovenous fistulas, we are able to control the flow. We see the fistula during our procedure, and we can control the success of our therapy. And we know when complete occlusion was achieved. So as in this case, for example, there was a fistula on the superior petrosal sinus, and this is the artery, this is the vein, this is a quite clear anatomy. And when we embolize with some coils and with some glue, we are able to see when the fistula has been completely embolized, and we know when to stop. However, if we are embolizing CSF venous fistulas, we never see the fistula during the embolization procedure. So this is something to consider, and this is something to keep in mind for the procedure. How is it done? So it's a standard transfemoral approach. Usually we take a 7 French sheath, on some occasions 5, and the target is to bring up your wire and our catheter through the azygous vein into the desired level of the fistula. So the important landmark here is the azygous vein, which wraps around or originates at the posterior border of the superior vena cava. And the important landmark here is the right main bronchus. So the azygous vein wraps around the right main bronchus, and this is the structure that we are actually looking for, the right main bronchus, because this is how we can identify the level where to take the turn for the azygous vein. As in this case, you can see this is the left main bronchus, right main bronchus. The patient is tubed, but it's actually quite easy and obvious to recognize the right main bronchus, and then you can easily get into the azygous vein. As soon as you're in the azygous vein, this is the anatomy books. This is also anatomy that was not familiar to me and most of interventional people, I would say, because we have not been doing angiography in this venous system. However, as soon as you have done your turn in the azygous vein, you can then go caudal and try to reach the level of the fistula. You can go into the azygous vein or the hemiazygous on the left side and get down to the desired level and exit at the segmental vein where the fistula is located. Usually you need quite a hard push on the contrast because you're injecting against the flow. It's not like in the arteries. You need really a good full cc syringe, 10 cc's actually, to be able to see the veins opacifying. When you're at the desired level, so this would be a catheter. We are now in the segmental vein, quite a hard injection again here, where we can see the key features of the venous anatomy. So these are the segmental veins. Then you can see the longitudinal system, which is the epidural plexus, and you can see connections between behind the dura or the epidural plexus, which is more of a small and delicate structures in the midline. Again, the same one in the lateral. You can see segmental vein, then going into the foraminal veins, and this is the epidural venous plexus. So it's quite a nice anatomy. So what is our goal? Our goal is to get to the desired level. Either what we usually use is a 7 French guiding catheter for the ones of you who are working in the angio suite, and park the catheter at the segmental vein, and then use a small microcatheter, advance the microcatheter to the desired level. I will go to the more detail in the next few slides. This is a patient with 2 fistulas in adjacent levels. You can see that both have been embolized with liquid embolics, something like squid or onyx, achieving as much of a filling of the foraminal veins as you can. The goal or the idea here, this is an AP view, this is a lateral view, to have that ring of fire almost, because this is where the nerve root exits and where the veins are connecting and then draining to the segmental vein. So this is the area you want to see filling as densely as you can. This is an overlay image of a CT myelogram and the CT after embolization, the onyx being displayed in green. As I said, you're not able to control the success of your treatment during the treatment because you don't have a contrast in the fecal sac. This once again having that filling. What is our standard setup? We usually do most of them in general anesthesia. The injection of onyx or liquid embolics in that area can be painful. because you're injecting around the nerve root. Standard approach is 7, sometimes 5 French sheet, which you then navigate into the Asiga system, and then use a microcatheter, and in some patients using the pressure cooker technique, which I'll briefly mention. There is a very nice work from colleagues again here, how to reach different levels. This was something we were very keen of knowing how to get to the desired level, and there were very nice illustrations which segmental vein to exit. However, by now we have learned and we see that sometimes navigating here into each and every segmental vein can be very complicated, and using the epidural plexus as your highway is actually a lot more easy. I'll come to that. So what is possible, and a lot of times it is a lot easier, that you navigate into any kind of a segmental vein, you enter the epidural plexus, and you go cranial or caudal to the desired level of the fistula, you exit there, and you embolize that desired level. This very much depends on the anatomy of the epidural plexus. This is some great work from Federico Canazzo from Montpellier, where he shows that most patients have an epidural plexus which allows you to navigate your microcatheter. However, on occasions, the epidural plexus, the structure, they might be so small and tiny that you're actually not able to navigate your microcatheter. However, in most patients, we see the type A and type B, which allows us to actually navigate there quite easy. So a case where this technique was applied, again, you can see this is the Asigas vein. The 7 French catheter was advanced to the segmental vein. However, our target fistula level is 1 level above. We wanna get up to there. The problem here is that the vein at the desired level has a very acute angulation, and navigating that vein is technically challenging. It's not impossible, but it's challenging. And in a lot of these cases, what can be done is using the epidural plexus as your friend. So what we do, we have a 7 French guide catheter parked in the level below, and then we use a small microcatheter which we navigate on the wrong level into the epidural plexus. However, within the epidural plexus, we are able to ascend or go cranial to the desired level. So you can see this vein is exactly the same vein we are seeing here. So this really helps you. In this occasion, used the pressure cooker technique. For those ones who are not familiar with that, you use a few coils to block off the vein so you don't have excessive flow of embolic material the wrong way. So you block off the vein and then start embolizing, and we're able to nicely fill the structures around the foraminal veins. Just an example, does this technique work? This is a patient done just recently with very typical classical findings of subdural fluid collections on flare and enhancement of the meninges. In this case, the specific thing was that there were fistulas at the lumbar level, and navigating down to the lumbar level can be actually quite challenging. So an option in these cases is actually to go through the iliac veins and go to the cranial through the lumbar veins, which was easily achieved in this patient. This patient had like 4 fistulas here at the lumbar spine, which we were able to embolize. And just 2 or 3 weeks later, you can see this is the follow-up MRI of the same patient, where you see the complete resolution and normal brain MRI in this case. The question is, when you're starting with it, can we be, how risky and how dangerous is it? Can we penetrate too far? Because if we are using liquid embolics, we could potentially damage the spinal cord, which would be a major severe event, adverse event. And since we are embolizing the foraminal veins, the distance is not very far. And if you look at that, those veins, if you mag them up, you can see that these are radicular veins, we are very quickly within the spinal cord, and an embolization within these veins would result in a terrible, terrible complication for the patients, and it's a no-go zone. So when looking at anatomical books and literature, what we can see is that the veins around the epidural plexus, actually there is a typical anti-reflux mechanism where when the vein enters the intradural compartment, there is a compression of the vein through the dura, and usually this is something which prevents, for example, epidural fistulas refluxing into the intrathecal compartment. There are some exceptions to it. There can be epidural AVF which actually drain intrathecal, but it's quite rare. So we believe that this is one of the mechanisms which makes our procedure pretty safe, because none of us has ever experienced a embolization within the intramedullary veins in any of these CSF venous fistula cases. What are the pros for the transvenous embolization? We are able to embolize multiple veins or fistulas during the same session quite easy, because as I said, you can go through the epidural plexus and can go to different levels, and also possible surgically, but it's definitely a nice alternative that there are alternative eloquent nerve routes that are like L4, L5, where embolization might provide a certain benefit. What are the downsides of doing an embolization with liquid embolics? You can see that afterwards, performing any kind of imaging afterwards is definitely something which decreases the imaging quality because of your beam hardening artifacts. So any kind of further myelography is going to be difficult to evaluate. For no matter how much experience you are, it is going to be difficult. And we have seen patients which do have recurrences at the same level, but more frequently on other levels. So we know that patients with CSF venous fistulas might have recurrences, a lot of times on adjacent levels, but still this is something where imaging quality is important. I'll skip this. After the procedure, this is a phenomenon that we observe, especially after transvenous embolization, quite frequently. So the patient was in a state of hypotension, and now the fistula, the CSF leak is being closed. What we see quite regularly is that they become in a state of hypertension. So they report different kind of new headache, mostly localized in the forehead, something that is very well compatible with hypertension, a phenomenon that has been reported in up to 80% of treated patients. Usually it's self-limiting. In some patients, people report that they use acetazolamide for a few weeks. Is transvenous better than surgery or vice versa? We cannot tell so far. I think it's important. Both techniques work very fine, and I think either one could work. It seems like the cure rates after surgery are better than after transvenous embolization. Does the treatment have an impact on the patient life? Yes, the treatment improves severely the patient's symptoms and quality of life for these patients. So take-home points for my side. SIH and CSF venous fistula being one of the causes is a treatable disease. I think this is the main message for everything. It's not about if we can do it better or the surgeons can do it better. It's the thing that it can be done. It's important to, when working in the venous system, to be familiar with the routes, how to get to the desired level. I try to show that there you can go through the epidural plexus or you can go through the lumbar veins. So there are various veins, and that helps us. The method of embolization is highly effective with low complication rates, and that's it. Thank you very much from my side.